I'll be sharing on the topic the importance of antioxidant and mucolytic in managing respiratory disorders. This is my conflict of interest. Receive honorarium for today's talk. Now, there's advocacy for mucolytic agent, a good one for many years. COPD, chronic bronchitis, bronchiectasis, pneumonia. In Western countries, cystic fibrosis. Those are conditions which a lot of phlegm, sputum reduction, retention, and very thick phlegm, and that really affects breathing. But today, I'm going to focus on flumasil, the N-acetylcysteine, which probably has the most evidence or data because it's been probably the longest around as well, one of the longest around. Now, for adults, there's adults dosage, and also for children down to the age of 2. Now, N-acetylcysteine is a cysteine added with the acetyl group at the N position, as you can see over here. This is important. The acetyl group is the one that ensures that it's stable, so that it can go through the system and not to be metabolically inactivated. With this, it can therefore go into our system and to exert its activity. I have another slide on this later. The tire group as well, the SH group. SH group is the one that provides the antioxidant property. So these are the two groups that's important in the molecule of N-acetylcysteine. Now, this is an important slide because it compares structurally between NAC with two other mucolytic that it's commonly in the market. So we have carbocysteine, we have endocysteine. Bromohexane is a very old drug, and in GH, I think almost everyone gets it. But I think this is a very weak antioxidant or a very weak mucolytic. Now, NAC differentiates from others for having a free tire group here. The tire group is the one that exerts the antioxidant property, whereas carbocysteine or adeocysteine is not free group. It is a block group, whereas there's no free tire group in mucosolvent or bromohexane. Because of this, N-acetylcysteine can boast of its potential antioxidant agent, but this has been proven in vivo. So what NAC does is that it has the acetyl group so that it maintains that it's structurally stable. Once it's in the system, you get cleave off from the acetylcysteine group and then combine with the glucose and glycine group, which form glutathione. Now, glutathione is the substrates that provides the balance in terms of our body oxidant and antioxidant properties. So this is one slide showing it, that you have your glutathione over here. So my cursor is also showing here, but actually doesn't show up there. Okay, over here. So this is the one, the glutathione, that actually enhances immune responses. At the same time, reduces all this antioxidant, all those oxidant, the free radical oxidant activity, either by viruses or bacteria, etc., or oxidative stresses. So this provides the balancing. So antioxidant activity, again, it goes mainly by the tire group, give rise to direct action. But also indirectly is because it can provide the precursor to glutathione, and from the glutathione it provides the balance between the oxidative stress and antioxidative activity. Mucolytic agent is important. Only one slide this, and that's only one study showing it. So as we know, there are a lot of disease stage. The mucus are very thick, and this is the cause for it to be blocking airways, etc. And NAC apparently are able to break off all this disulfide link bridge, so making it loose and able to cough out. Anti-inflammatory is interesting. We have some data, again this is in vitro data, showing that it actually modulates activity against IL-6. IL-6 is a very important inflammatory cytokine. A lot of times the neutrophil, when we have neutrophil inflammation, IL-6 is the one that recruits neutrophil. So if we have this which can go against the IL-6, it provides its anti-cytokine activity. And also apparently it modulates neurogenic inflammation through this neurokinin A. But today I'm going to talk about clinical evidence. Clinical evidence against for use in COPD. It reduces exacerbation, improves symptoms. Chronic bronchitis. Okay, chronic bronchitis can be with COPD or without COPD. Smoker's cough can cause chronic bronchitis. Again, evidence that it reduces exacerbation, reduces symptoms. And then we have possibly pneumonia via disruption to its biofilm, and then possibly COVID-19 infection too, which there's a flurry of studies happening during the early stage of COVID antigen infection epidemic. And also safety up to a year. And we talk about 600 daily or above. Okay, this is an important study, and this is published in Lancet. So it's a very important, impactful paper and in a high impact journal. So it's a randomized double-blind studies. It is relatively old study. It's in Chinese population, a huge number. It's on moderate to severe COPDs. Exacerbation rates over 12 months, those included are those already have exacerbation at least once in the year before. So these are COPD with frequent exacerbations. So one of the largest single study of NAC in COPD. This is the main study result. So this is the plot chart that's showing what favors N-acetylcysteine or what favors placebo. And you can see here, especially in moderate COPD, the blue here, it clearly favors Flumasil in terms of reduction of exacerbation, and not so much in severe. It crosses the 0, the 1 here, but overall it makes it a positive study. So it must be shown, noted that it's at the dose of twice a day. So not once a day, it's a 600 twice a day, reduce exacerbation, especially for moderate COPD, over a year. And it's safe over a year, and you look at it, they're all comparable. Now, N-acetylcysteine are mainly GI symptoms, so gastrointestinal here, you can see 2% versus 1% in placebo group, and this is not significant. But I like this study. This is in 2019, more recent. This is a post-hoc study of the Pentium study. So it shows, it studies further whether smoking, either you're ex or current smoker, or whether your concomitant use of inhaled steroids, how does that fare if someone has N-acetylcysteine? This is interesting. So severity, exacerbation severity significantly reduced for those who are without ICS. So COPD, as you know, some patients we treat ICS, some patients no need. So the GO guideline nowadays advises us or recommends us that we should just use bronchodilators. The more effective the bronchodilator, the longer acting the bronchodilator, the better. So only in a certain group, for example, group D COPD, we have a lot of exacerbations and a lot of symptoms, then we will probably add steroid, inhaled steroid. Generally, there are two criteria. One is that you are frequent exacerbator, and secondly, nowadays they advocate blood eosinophils. So a COPD comes to your clinic, and if you want to make sure or want to decide, help to decide whether you want to give ICS, you can do their full blood count and look whether they have eosinophil counts more than 300, and then you can consider using inhaled steroids. So not all COPD will be treated with ICS, but for those who are not treated with ICS, they seem to benefit more with Flumasil. This is the study showing it. And there's also another data which shows that if you are a smoker, either current or ex-smoker, you benefit more as well with Flumasil. But I don't have the slide here. So much so that in GOLD Guideline 2003 this year, you can imagine that mucolytic and antioxidant agents are now being recommended, especially those not taking ICS. Then you can think about using N-acetylcysteine because it has data to show it reduces exacerbation and improve health status. Now, how about chronic bronchitis? So this is a review, systematic review, and this is an old study in 2000 in European Journal of Respiration, European Respiratory Journal. So it's an old study, and you can imagine that Flumasil has been used since 1976. It's an old drug. And it's 39 eligible studies. That is 2,000 over patients, over up to 2 years studies. Now this is interesting data which shows that if patients without exacerbation with placebo or patient without exacerbation with NAC. So you can see that there are more studies showing that patients would benefit by having no exacerbation if they are taking NAC. It supports the use of NAC for chronic bronchitis, but it's an old study without any serious side effects. Biofilms, there's a good study. This is more recent, 2016. And these are good people. Clive Page came to Penang a few months ago. And I'm still glad to see he's active. During my years, when I was doing research in London, I was work under his department. So he works upstairs. He's a professor in that department. He's much senior than me, but he is a really, really good man. So I'm glad he came to Penang. I was surprised to see him a few months ago. At that time, I was advocating a new asthma medicine. Not so new. You know, we use Nulin tablet for asthma and COPD. That's a second generation theophylline. It is less side effects and is more anti-inflammatory. So far that has been good. So it's now available. So we can use that for COPD now. Now biofilms, apparently again this is a lot of studies over here. And we're talking about different types of organisms. We have, I'll read to you, we have E. coli, we have Klebsiella, we have Enterobacter creusia, which is very hard to treat because they tend to be resistant to a lot of antibiotics. Protist species, Pseudomonas. A lot of chronic lung disease is Pseudomonas based. And these are the ones apparently are shown that their biofilms can be disrupted with NAC. So with this, it seems to be able to also provide an adjuvant treatment for patients with pneumonia. COVID-19, I just show a few slides. So these are high dose. We're using high dose. And these are the studies done, very recent because of the COVID. So in the first one, you have study reports. There are 80 patients. This is 2022, most recent. And it shows that it can target antioxidant and preventing antioxidant oxidative damage. Then 2021, we have some observational retrospective study, and there are 82 subjects. Shows that it reduces the risk for mechanical ventilation and mortality. Then 2021, we have a large cohort study of 1,083 patients, and these are the patients seemingly, the finding is that it shortened the length of hospital stay compared with those who did not receive NAC. This is early days of the pandemic. And then we have 2022 again, so recent ones, real world study. This is 2,000 over patients, and it shows that it potentially reduce mortality despite patients being older and more frequently male and have more comorbidities. But it has to be used at high dose. So in other words, the NAC, from my understanding, is that if you give just one tablet a day, the 600 dose, probably not enough. You need twice a day at least, or 3 times a day, to have anti-inflammatory. Otherwise, it's more mucolytic agent. That's my take. Now, safety, I like to point out this study because it's important. This is recent. So this is including newer studies. Earlier, that one was so long ago. But in these studies, talking about 600 and above, up to 3,000 milligram a day. Most studies use oral, and these are also for pulmonary fibrosis patients, cystic fibrosis. The safety profile shown to be comparable with those with placebo. So case studies, I want to show two. It's a 45-year-old Indian male, chesty cough for 1 month. So she did have COVID infection, but it's category 2 in last year, 2 years ago. She's a smoker, 20 pack years, hypertensive. Chest is clear, so there's no wheeze. X-ray is normal, so there's no pneumonia. And then the lung function is good, so it does not have COPD. This is chronic bronchitis. Oh, sorry, I shouldn't have said this. Too late, bronchitis. So the differential obviously is smoker's cough, postnasal GERD. So people with chronic cough always think about either is it nose or upper GI. That's the two things to think about for chronic cough. Treatment, give some steroid, give some my favorite Clasid, which I also like it because it has anti-mucolytic property. I issue it for 5 days. Then follow up, she felt better but still chesty. Then I just give another Flumasil once a day only, 1 week with improvement. So it's like a bit of complement each other. Still some antibiotics. If it's not clearly big infection, probably just go for Clasid. If it's a young person, no diabetic, I'll give some oral steroids. She will help. But this patient is still inpatient now, but she has improved much. She's a young lady, but she has progressive limb weakness for a year. And then she came in, cannot breathe, and we have to intubate her. And now she's on a tracheostomy, and she's on the NG feeding tube, which we are now changed to a PET tube. So percutaneous endoscopic gastrotomy tube, so that she doesn't need a feeding tube here, and also to reduce the risk of aspiration. She has some form of neuromuscular disease, undefined. We didn't do too many genetic studies because if we find any genetic component, I think her insurance will not cover anymore. So this is what the neurology does. But even if it's any genetic, probably is more academic. Probably for family counseling is important, but she's a single woman. I don't think she'll marry from now, but That would be the purpose for genetic study. Then she become breathless again and chesty while in the inpatient. Then a significant left lobe collapse consolidation. It's probably aspirated, but probably also because she cannot cough. So not only she have limb weakness, she have diaphragmatic weakness. So therefore she cannot cough. If you don't cough, you retain phlegm. Then it's the left side, she kena this time, CT shows very significant. Because X-ray can't show very well because it's blocked by the heart here. So a lot of times it's quite deceptive. You look at her, chest X-ray looks okay, but because of the heart, it blocks what is seeing on the behind the heart. So treated with tazozine, chest physio, which is the most important, suck a lot, the trachea, give a Flumasil twice a day, and then chest X-ray improve almost completely in 7 days. So most likely it's mucus plugging with lung collapse instead of just an infection. So that's the X-ray with left lower collapse over here, collapse consolidation, and easily improve. You can see the diagram very clearly. So the silhouette sign now is negative, so we know that there's no consolidation over here. So in summary, NAC, it's more than just mucolytic agent. It's anti-inflammatory, it's antioxidant. So hopefully with all this property, it will improve the lung function, reduce symptoms, reduce exacerbation in terms of COPD or chronic bronchitis, and fewer hospitalization. So Flumasil A, the recommended dose is 600 daily or twice daily, 5 days or 10 days. Influenza, smoker's cough, COPD, and it can give up to twice a day for its anti-inflammatory property. Children are down to 2 years old, twice a day or 3 times a day of 200 milligram. So this is 200 milligram, not 600 milligram tablet. Again, similar. Okay. Thank you very much. Thank you.
Hello, Dr. Parthiban Sungap Tani. Doctor, in N-acetylcysteine for asthmatics, acute asthma attack. So how do we proceed? Sometimes they can't tolerate or cause some adverse effects.
I think I will do the same. So 600 BD. 600 BD. Maybe try with daily first. But if it's a younger person, straight away, twice a day. I usually ask them to take after food. After food. But it is adjuvant. So in other words, you still have to give your steroid. You still have to give your nebulizer or whatever. So it's adjuvant. And if you suspect there is an infection, you give some antibiotics. But if they recover from their asthma exacerbation, you're giving enough steroid, and then also antibiotic enough. They say, oh, I'm much better, but I'm still having some phlegm. Then I think just give Flumasil enough, single agent enough. Rather than another course of steroid, another antibiotic. That's what I think I'll do.
Thank you.